Hey guys, welcome back to another episode of the Mind Muscle Connection podcast. Today I have a very special guest on, Dr. Karl Nadolsky. He is a clinical endocrinologist and obesity specialist at Holland Hospital in Holland, Michigan. Hopefully that is still the case there. I did grab that online. And is a clinical assistant professor at medicine at Michigan State University, and he is a co-host of the Docs Who Lift podcast as well too. So thank you, Dr. Nadolsky, for coming on today.
Absolutely.
Yeah, really looking forward to chatting with you. You and your brother do a ton of great work in the field.
Thank you.
It's really an honor to have you on here. So real quick, any new guest I bring on, I just like to go over your background. How did you get to where you're at today?
Yeah, so the basics of it go way back to when I was a kid. So I was really into working out as a little kid. My parents got me a Hulk Hogan workout set when I was like 6 years old. And I started going to the high school gym, which started off as like just a small little universal gym in the early 80s with my dad. He was the wrestling coach. He coached football and he was a science teacher. And my mom was an elementary teacher. We were very into academics, science. I was very interested in human biology, as you can imagine. So then going through high school, continuing to love working out, playing sports, wrestling, football, I did some track, sailing was my summer sport kind of thing. Maybe being a little bit more interested in my own physique than potentially what is appropriately mentally. As we know, guys have some body dysmorphia, whatever. I did care about that for sure. Wanted to make sure I was not only being healthy, but muscular, lean, and all that stuff. And then going through college at Michigan State, I was wrestling for Michigan State. So then became even more in tune with that stuff, was doing a pre-med sort of thing because that just made sense. Like, how can I help people with my interest in health and sports and wellness, that sort of thing. And just started, and I did essentially exercise science. Kinesiology is my undergrad plus pre-med. So I was also doing a little bit more nutrition science, at least learning about what was going on out there. And then ultimately went to med school based upon that sort of background. My mom's younger sister is a cardiologist. When Spencer and I were visiting her one year,
Awesome.
and we were talking about nutrition and insulin and all this stuff, she said, "Hey, sounds like you should be an endocrinologist." And I was like, "What the heck is that?" Then in med school, in the first or second year, we had, well, probably the second year, we had a month of clinical endocrinology stuff. And endocrine hormones, they're a little different. And I know like everyone out there online thinks they're like a hormone expert, but the reality of it is a lot more complex. And so the basic endocrine systems were more difficult for some people to grasp the concept because it's just different than other aspects of medicine and physiology. But for whatever reason, not just like the obesity, diabetes stuff, everything else made more sense to me. And it was like really easy to me. Then in residency, I was in the Navy, did my internal medicine residency at Naval Hospital, Portsmouth, Virginia. We had a great residency program with all sorts of different specialties from cardiology to endocrine to all the other ones in my internal medicine program. And everyone really reinforced that concept like, hey, you either need to go into cardiology or endocrine because that's just what you're good at. And I have a passion for it. And that's how I feel like I can help people. Yada, yada, yada. Went on to fellowship at Walter Reed National Military Medical Center, had a great training, great mentors there, was taken under the wing by some of the national leadership for some of our national organizations to help with obesity guidelines, education, stuff like that. And that's how it got me to here.
Yeah, awesome. Yeah, no, I always love hearing the background. And like you said, a lot of people in the fitness space, right, think that they know everything about hormones and stuff like that. So I'm sure, you seeing some of the stuff out there, I'm sure it probably really grinds your gears there with that. So do you, I guess, also being an obesity specialist as well, too, I guess you obviously combine those two, and I'm assuming you use those together today in your practice and everything like that.
Oh yeah, absolutely. Yep.
So is it
I've had to learn a lot. If you would have asked both Spencer and me, we talk about this all the time. If you would have asked us 20 years ago when we were in college and college athletes, maybe even going through med school, we thought we could fix everyone with nutrition and exercise and stuff like that. And as it turns out, the science and the real clinical difficulties are a lot more complex.
Yep. Yeah. And I can relate to that too, right? Where it's like, oh, just diet and exercise. And again, we know that's great. And I know you guys always talk about how that's the main thing that you guys are focused on. But in some situations, you obviously do need to you do need to do other things, potentially there, medication, whatever it may be with that. So how do you, I guess then what does day-to-day look like for you right now? What are the type of patients? What's your day-to-day look like as of now?
Basic day-to-day, and we're busy. For better or worse, I have to get up and I have to go through a lot of patient messages early in the morning. But then I get into work. And we essentially see patients from 8 a.m. through 4 p.m.-ish and change. I have a great team of medical assistants, dietitian, diabetes educators, and a couple of other colleagues to help with follow-up. We do have an exercise specialist within our midst that we have to do some still program development stuff, get things working. As you can imagine, healthcare is dysfunctional. Insurance doesn't like to pay for what it should pay for, yada, yada, yada. But that's what we do. That's basic day to day. I see a mix of obesity through type 2 diabetes, metabolic stuff. So that's certainly my special kind of subspecialty. So we do a lot of that stuff. But I also do all general endocrine things from hypothalamic pituitary disease, to thyroid disease, adrenal disease, bone metabolism disease, testicular ovarian failure, menopause, all the things.
Okay, yeah. So again, not just obesity, there's other things as
Mm-hmm.
well too that
Yeah.
are going to be involved with that. So with your patients, how in depth are you able to get? And I know again, you're super busy, so I'm assuming that's probably the a good thing. You're busy, but also probably the downside as well too. You're not able. How like in depth are you able to get with your patients, and what does that kind of look like?
So it's very important for me. This is a real issue I have with healthcare. When we get paid the way we get paid just for seeing patients, which is not how it should be. There are endocrinologists and other doctors who are essentially burned out, whatever, toaster ovens, and they just crank through patients, not a lot of time spent, and they get rewarded for that, unfortunately, in this day and age. I can't do that. It's unethical. We get paid fine. I am very fortunate that my system supports relatively decent time to be able to spend with patients. So I have new patient visits that are scheduled for 40 minutes. They often can go an hour, and I have to make up for it some other way, but I'm able to do that. And so I do probably more nutrition history, exercise history. I try to depend on my dietitians for that, but it's because it's such a passion of mine. I do spend a fair amount of time with each person doing that, maybe more than is clinically or time-wise, time efficient, but I think it's important. And sometimes we have to spend more time with people for the weird endocrine things to try to really figure it out. I had a story today about, if you ever listen to our podcast, we rail against the whole functional medicine kind of alternative world and who they get all into like inappropriate hormone evaluation. And I had a patient essentially referred from Cleveland Clinic's functional medicine department, which is, of course, founded by Mark Hyman, and they did it just for money. All the other real specialists at Cleveland Clinic are embarrassed by it. But this person went there for a variety of things that need to be evaluated appropriately and got Dutch testing, which is a BS thing, not even real. Told she had the small intestinal bowel bacterial overgrowth, which may or may not be true. It's not like they got her in with the gastroenterologist who would be the ones to do that. And just all sorts of frustrating stuff, and ended up having to refer back to me to actually do the real endocrine workup. And she had to pay thousands of dollars to do that. So very frustrating, but we do have to spend time to figure out the true root issues, not the marketing scam of root causes. We really do have to do that. And so sometimes it takes a lot of time and then follow up. And we do lots of labs. And that's the endocrine thing. We do lots of hormone testing. It has to be within the appropriate clinical context. We have to think about our clinical suspicion and statistics of, are we going to get false positives, false negatives? Labs are not just perfect magical numbers that can tell people what's going on. And that's why we also don't like it when people just start going out and getting labs for no reason and done in the inappropriate way and stuff, because it causes problems. So that's a soapbox that I just went off.
Hey, that's why we brought you on here for that. Yeah, no, I like you said there, that's something that I commonly see too, where clients will say, "Oh, hey," or certain people like reach out and they're having all these, they're struggling to drop weight, drop body fat, whatever it is, and they're sick of, they feel like something's wrong with them. So they reach out to these things. And then, like you said, like the gut health side of things, it's like all these supplements, all these tests you need to take. And it's okay, now you're spending hundreds and hundreds of dollars on this when, like you said, I'm sure most of the time we know the gut's important, but it's probably the basic things that people are overlooking there with that.
Right. You are exactly right. Yep.
And so again, like you said, some of these things can just be very frustrating. And then, like you said, you got to go in and actually do the work there to help them there with that. So what does like the nutrition interventions look like for you in the training? I know you guys are really passionate about weight training, resistance training at the cornerstone of everything. How in depth are you able to get with the nutrition interventions and the training interventions?
Yeah, so I think I'm able to get a little bit more in depth with nutrition because I can do a relatively decent, good kind of dietary recall and get the kind of the basics of what people are doing. I chase after the low hanging fruit. If they're drinking sugary drinks, I have to teach them that the diet drinks aren't bad per se, like the other people put out there. And that's a true scientifically confusing thing, right? We can get into that someday if you want. That's one thing. So a lot of people do that. Restaurant food, the obviously highly processed, refined, hyper palatable, calorically overwhelming dietary environment we live in. So I chase after those things. I try to, depending on what their individual situation is, if they have, even type 1 or type 2 diabetes, where we're really treating their obesity and the sugar in their blood from the food, we absolutely will try to cut some carbs anywhere we can, empty unnecessary sugars where we can, still allowing people to have some fun, but replacing like starchy, refined processed carbs with a lot of vegetables, beans, legumes, fruit. I'd rather them get their carbs from that. And then as far as like fat, if they're eating a kind of a high fat diet, or if they're like they decided to go keto because of people online, make sure they're not doing like the ribeye and eating butter all day keto, but more of a Mediterranean pattern, more nuts and seeds, olives, avocado, fish fat for the cardiovascular benefits. But really we individualize it, right? So some people want to do some versions of intermittent fasting, time restricted feeding. We can combine that with anything. Some people we not want to cut their carbs down, their fat down, combine it with a Mediterranean style pattern. People want to be more plant forward. They want to be more carnivore, so to speak. Whatever, we can modify and personalize their dietary plans, but for their specific health goals. And everyone's a little bit different. If they have obesity and any of the complications, we have to create an energy deficit one way or the other. We do a lot of meal replacement shakes because that has some of the best evidence, no matter what the people out there that thinks because they're processed and they're not real food. I can't help it. The science shows that there's some of the best things out there that can help with obesity, putting diabetes into remission. So we do a fair amount of that, but we don't go strict with it because I think that's just too hard to do in a real world setting. But we combine it with the other stuff and we just personalize it for people. Everyone's different. And then I let my dietitians do more. I let them really dig in. And if people want to come back and follow up, some people, they take what I say, maybe they need medicine to help them, and bam, they go do it on their own and they do great. Some people will even say, hey, I need the accountability. I know what to do. I just need your dietitians to help keep me accountable. And then we'll do that too. And then there's a whole mix in between.
And do you guys ever get to the point to like track calories, macros, or is that again just
sometimes
independent?
Yep. Sometimes I personally don't like to do that, but some people do. Certainly currently my brother has a little bit of conflict of interest because of Weight Watchers stuff, but some people like to do the point system with that. Some people just do better with My Fitness Pals. I have sometimes usually younger people who get into counting macros, and we'll come up with some macronutrient goals for them and adjust them and stuff like that. But yeah, everyone's a little bit different.
Yeah, my experience with that is really depends on the person. And again, there's obviously with any of these nutrition interventions, it's like each one's going to have their pros and cons to it. And just like you said, you need to take the individual into consideration.
People out there don't like to hear that though. They don't, everyone that, the only things that get traction online are you got to go full on carnivore, keto, vegan. Nobody wants to nuance and personalize anything, but that is what's best for people, I think.
Yep. Yeah. No, they want the black or white. Like, hey, this is the one you got to do. This is the best one out there. Cool. So again, I know you guys are obviously obesity specialists. So I'm assuming a lot of the main, it's weight loss is a big thing that you work with here. I wanted to just talk about the importance of like body composition, right? Like how important is that? Like, again, people hear weight loss, and is there anything where people maybe take that too far from a weight loss perspective, or is that less common than I think? Or yeah, what is that kind of look like?
For people who have disease, real obesity, and obesity technically is not just excess adipose tissue, but also abnormally distributed adipose tissue or dysfunctional adipose tissue. That's why BMI isn't a perfect thing, right? Because everyone can have slightly different body composition within the same BMI. So thinner people, less muscle, more abdominal obesity. When the healthy fat cells aren't working, that's the first step in essentially insulin resistance in that spectrum. And everyone has like a genetic different threshold for that. Their fat cells just say, oh, all right, we're done storing. So go into the visceral fat, and the liver, the pancreas, the muscles, that we call it ectopic. It's not where it's supposed to be. Cranks up insulin resistance, inflammation, type 2 diabetes, heart disease, fatty liver, all those things. Weight loss technically helps no matter where they are on their BMI. However, the devils are in the details of how we do it. So everyone needs to strength train some way, somehow, on any level, because muscle is metabolically healthy. It just is. There's no controversy there. Everyone needs to do something like that. I would say the thinner people with a low BMI but abdominal obesity, we could call them sarcopenic obesity maybe. They really need to focus on strength training and probably more of a Mediterranean diet pattern, just like everyone does, but maybe more hardcore without maybe aggressive caloric restriction at first, But they still, in the studies, they still get the same benefit when you see that 5, 10, or 15% weight reduction that correlates to health goals. So they have diabetes, fatty liver, et cetera. They still get those benefits from the weight loss per se, but we want to do it in the right way. Optimize muscle mass, minimize fat, consider what their sort of personal, we call it a phenotype is. We have people with BMIs of 50 who are metabolically very healthy because their healthy fat cells work. They just also have the increased risk of cancer, knee arthritis, sleep apnea, even if they are still metabolically healthy. And maybe they're working out and keeping themselves at bay metabolically, but those are individualized genetics and stuff.
Yeah, so the genetics are going to definitely play a role in that as well too. But like you said, even again, people kind of poo-poo on BMI, and I know there's some pros and cons to it. But generally speaking, the higher you are on it, it's hey, even having most people don't have this issue, but having too much muscle and too much weight, body fat on top of it could potentially,
Yeah, it's true. And even Spencer and I, we've always had large muscle mass. And so this is another one. If you would have asked us 20 years ago, we said, BMI's BS. Look at us. Our BMIs are 27, 30 or whatever they were. And we're lean and ripped and healthy. But he may have had sleep apnea. He's trying to be a heavyweight. We joke around about it, but it's not wrong. And I think now in our post-college careers, we're still pretty muscular, but we're pretty darn healthy. We're very lean. But BMI is actually pretty darn good for a population, not an individual per se, but nobody with a BMI of 35 doesn't have obesity, right? And if they don't, if it's truly that they're ripped at that BMI, I am never one to cast stones and suggest people are on steroids, but they probably are at that point. Professional bodybuilders, that's just part of their game. Unfortunately, it's bad for them, but that's what they do. They have BMIs that high with often low body fat. That's just a different thing. That's a different problem. But the BMI is still not good, probably at that point. If you're a 22-year-old Division I NFL linebacker and your BMI is 30 and you have 6% body fat and you're really healthy, awesome, great. That's an individualized thing. You don't have obesity. But generally speaking, for the population, BMI is pretty darn good. And then we can split those hairs within that, do waist circumference. And then more importantly, the clinical staging of what's going on. Is it doing any harm? What's the risk of it doing harm, et cetera?
So you mentioned muscle is very metabolically healthy. What are some other like kind of benefits there of making sure to like in the weight loss process or just in general, like you said, even people that have low BMI, but they have, like you said, high visceral fat, low amounts of muscle. What are the benefits of making sure that you do have muscle and focus on that side of things?
Yeah, so muscle is clearly correlated to what we call the metabolic health stuff. So the insulin sensitivity, type 2 diabetes, heart disease risk, the lipids, the high triglycerides, low HDL. That's that metabolic syndrome, insulin resistant pattern of cholesterol, lipoproteins being carried around. Good for the liver fat, the risk of liver fibrosis from fatty liver. But even beyond that, it's good for mental health. It's good for functional health. If you're more functional, you're going to be able to do the exercises for longer in your life, even if you have to switch them up because you get bad hips and hip replacements like I did, but I can still do other things. I still lift hard, do other types of things. Still do light leg exercises for high volume and my metabolic health personally, and hopefully do that forever, because that becomes a problem too. So we have older people who have diabetes and now they're also frail. That's a tough situation because now they can't exercise and we got to slowly get them back to it. And if we can get everyone to do it from the beginning, that would be awesome. And so it's so many health benefits, and it's a vicious cycle, right? So if you're not doing it and then you're not as healthy, and then you can't do it, and then you're injured, and it's just, and we got to somehow reverse that cycle, and prevention would be key. So if we can get everyone to do some sort of exercise, some sort of strength training, real simple basic stuff. The other problem is trainers always overcomplicate it, right? A lot of people overcomplicate the strength training. You don't need to do anything funky. Just get it in and give it a decent program. I think the funkier stuff is more important so people don't get bored rather than having any other benefit. So that is a point, but keep it simple. Get it in.
Yep. And even using, this is something I've changed my mind on. I don't know if you guys have focused on this too, but like a lot of times when I first got into it, like, oh, you need to do barbells and stuff, but it's like machines, even doing machines.
Totally. Same. Absolutely. In fact, I'll tell you, growing up, we had, like I said, I had the universal machine when I was a little kid at the high school. Then we got more of the free weights, more barbell, dumbbell, all that stuff. And then when I went to Michigan State, hammer strength was the thing. And I love hammer strength stuff. It's this combination of machine free weight sort of thing. It's interesting that in the sports world, I feel like it's coming back around almost the other direction. So at my own high school, where I help out a little bit, suddenly the hammer strength stuff is gone and it's all more functional barbells. And so that's whatever, that's fine. But I'll tell you, my patients are not necessarily going to do a lot of free weights. I can still do a fair amount of them. I don't expect them to do it. What if they don't have a spotter? If they can get to a gym and go through a circuit of machines that just guide them through the process, push, pull, leg. Oh my God. Machines are amazing for health. Definitely
Yep.
no shame in doing machines. And I do plenty of them.
Yep, safe, like you said, generally safer. And then, like you said, I think too, the other thing is the barrier. People think that they need to do a lot more than what they actually need to do with it. And
Mm-hmm.
it's, again, obviously, if you're trying to be Mr. Olympia, yeah, you're probably not going to be able to go in and do 15, 30-minute quick
Right.
workout like that. But I think people underestimate how much, like how little they have to do to really reap the benefits of it.
Yes, absolutely. And I will tell you personally, I have to do that these days too. Now, I'm just basically maintaining to try to hold on to my health and stuff like that. But yeah, with kids and all these things, they're doing their workouts, they got their practices. I'm working all day. I go 20 minutes, I do it as kind of hard as I can. Yeah, maybe I don't get as much rest in between sets as I would maybe prefer if I were my old just single meathead trying to grow muscle kind of guy. But boy, tell you what, I can maintain pretty well. And yeah, you might not make a lot of gains if you're an accomplished athlete or something, but boy, everything's good for you.
This is something that I've been thinking about, so I just wanted to get your thoughts on it. Do you feel like part of the issue with people attempting to lose weight, maybe they try to do these kind of like drastic weight loss. They know they need to lose weight, so they do these pretty drastic weight cuts, and they're not really weight training. They're like, oh hey, I'm just gonna wait till afterwards. So people lose muscle, and then we know that the weight rebounds, stuff like that,
Mm-hmm.
potentially. Is that an issue that you see here where people do have? Is that a pretty common issue, or do you think that's less?
Yeah, I think it's part of it. I don't think it's as much of an important priority for everyone to like talk about all the time necessarily for that weight regain because there's so many other biological reasons why people have essentially different set points or biology driving back the weight up. It's more or less from the diet. So if you look at some of the studies on the Biggest Loser population from years ago when they talked about the metabolic adaptation and all these things, their metabolism was a little bit lower than what it should have been. Their muscle mass was pretty good though because they were exercising. And then some of the other studies all jiving together. It matters, maybe not as much as we thought for the weight regain, but it's more about the health. And that's what I tell people. It's literally what's on the inside that counts. I don't care what you look like per se. I care about what health is the muscle benefiting you. And yeah, it's not as much about the weight maintenance and regain, but it definitely plays a role. More muscle helps with metabolism. It's going to help you maintain and exercise in general, high exercise volume, weight training, aerobic, all that stuff is really important for weight maintenance if we're not using medications and things like that.
Yeah. So what do you see are like the biggest issues with people trying to lose weight with obesity, right? What are maybe some things that kind of get in the way, and like what I guess what tends to cause them to not be able to see the results
Yeah.
that they want to see?
So generally speaking, most of the time, it is their individual variable genetics. So genetics loading the gun and then our environment pulling the trigger. And then, so we have a very complex energy balance regulation system. Our hypothalamus is controlling the whole thing, getting feedback from like leptin hormone from our fat cells, from like the GLP, GIP from our intestine cells, the ghrelin hormone from our stomach. That's the hunger hormone. And then you got all like the craving hormones in the brain working against people. And then you throw them in this environment we live in that's hyper palatable, high processed, crappy food environment. Then you throw in all the other environmental things that we know about, anything from endocrine disrupting chemicals to viruses to you throw in the microbiome. Everyone has different brown fat stuff, all these problems. And then it's keeping some people at a weight that is not healthy. And it can come across as hunger, cravings, the food noise you hear more about now because these medications cut out the food noise, people thinking about food, preoccupation with food. A lot of people think they're not eating much, and it turns out they're just getting empty calories in and they didn't even realize it. Sometimes they can figure it out, sometimes they can't. But then once in a while, it requires giving them medicine to see if we can treat the underlying biology that's working against them. And then they're like, oh, now I'm losing weight. I didn't think I was doing anything differently, but it turned out, oh yeah, I was eating here and there, whatever it was. And then they're able to lose the weight, keep their physical activity up, keep that metabolism up and get down. Then it gets more complex sometimes, but that's the basics. It's just the biology driving energy intake in this crappy environment we live in.
Yeah, it's funny. People are always like, I don't understand why people are gaining. It just makes sense, right? The environment, and then, like you said, the biology side of things
Hmm.
as well too. And I
Yeah.
think you mentioned earlier how with the weight training, it's this vicious cycle. But I'm assuming it's probably a vicious cycle as well from an obesity standpoint, because
Hmm.
as you get obesity, you gain more weight. It's like your hunger cues are all out of whack as well too.
Yep.
So it's this vicious cycle. And like you
Yeah.
said, people end up just consuming more calories than they
Yeah.
think, even though they don't really feel like they're eating a lot.
Yep.
And so it's crazy how I think coming from the fitness space, the body composition space, it's eat less, move more. And it's like that's generally good advice, but it's like it
Yes.
does go deeper than that. People kind of
Yeah.
get the biology side of things. And so
Yeah. It's not wrong. It just doesn't help. It's because we
right.
got to find different ways to individualize it and maybe treat some of the other stuff. Maybe we need meds and surgery sometimes. That's what we're here for.
If it was that easy, you and I probably wouldn't you wouldn't have as many patients. I wouldn't work with as many clients either if it was
That's
that
true.
easy.
Or yeah, or there just would be enough of us to take care of everyone who really needs it. So
That is true.
that's yeah.
And so you mentioned medications, right? So I did want to bring
Mhm.
you on about GLP-1. This is something
Yep.
that people have been talking about a ton lately. So I just wanted to get your thoughts as obesity specialist. I'm sure that you obviously know a ton about this. So maybe
Mhm.
just give us the lay of the land of it right now, where it's at, and
Yeah.
any questions that
So
come up.
basically, a lot of people think this is all new. This has been going on for well over 20 years. The first research on this was going back, gosh, even before the 70s into the 80s when this was being discovered and figured out. And then I was a med student. I hate to tell you how long ago this was now. I can't believe it. But I was doing my rotation in endocrine as a med student in 2007 or so. And that was around the time, I think Byetta twice a day shot for type 2 diabetes was approved in 2005 or something like that. And so I was very familiar with it. It was new at that time. Good for weight, good for type 2 diabetes, very good for glycemia. The next one that came out was the daily Victoza shot called liraglutide. And then the first time any of those were approved for obesity was when Victoza at a higher dose was approved as Saxenda several years later. And to some degree, those were already breakthroughs in type 2 diabetes. So they work on the pancreas, they improve insulin response to blood sugars, essentially to eating. They signal up in the hypothalamus and brainstem and maybe a ton of other places to help reduce that food noise, help with their dietary efforts and the weight loss. They also work on the liver and glucagon aspect. And then but the weight loss was relatively modest with those at first. Good, but modest. Very good for sugars. Liraglutide was the first one of these to show a cardiovascular benefit in those with type 2 diabetes and high heart risk, essentially reduce cardiovascular death. I happened to be at the American Diabetes Association meeting that year, and it was like being at a rock concert. I got swept into the arena because all the nerds we're all like, yeah, this is amazing. Because that's what's important. It's not just the weight. It's not just blood sugars. It's what are we actually doing that's good. And this was the first of those meds to show that we were reducing risk of heart attack, strokes, and death. And then they were able to modify these molecules to be weekly and more potent. Hence, then Ozempic was approved for type 2 diabetes, found to have really good weight reduction, studied for obesity, a little bit higher dose, very good weight reduction with that. Then it was approved as Wegovy for that. And then, of course, then most recently, we had the tirzepatide approved for type 2 diabetes as Mounjaro, and then for obesity as Zepbound. And these have not only have the best blood sugar benefits for people with obesity and type 2 diabetes, but also the best on average weight reduction and those clinical, like the 10, 15, and now we're talking about 20, 25% weight reduction, getting closer to the bariatric surgery type amounts of weight reduction that put disease states that we talk about into like remission essentially. And so they're really good. And all the benefits for those who truly need them outweigh any of the risks that people hear about out there, but they are still drugs. Drugs have pros and cons, risk, benefits, cost. That's the biggest issue actually right now, and availability. And so that's where we are with those. And every single study that comes out essentially shows dramatic benefits. They also sometimes expose some hypothetical or possible real risks. And yeah, we shouldn't just be giving them to everybody. I'm not going to take it to help me lose a percent of body fat. People with very mild obesity by both BMI and also clinically, meaning they don't have any complications, really, they should not be the people to get these. They should maybe be using other items. These are more intensive therapy. Now, if they were dirt cheap, maybe a little bit more relaxed with that, but they're still drugs. So the side effects you hear about, they're real. Sometimes some of the stuff out there is fabricated and exaggerated and not a statistically significant thing. We did our podcast recently on do they cause people to go blind? Not really. There's always some truth in there somewhere. Some study raised the concern, not in the big trials. But yeah, I'm not going to take it just for fun. So people should not do that. We should, and the compounding stuff, who knows what the heck that's. So I never tell anybody that I would ever give it to a patient or a loved one or anything like that, but people are desperate and willing to pay for it.
Is it usually somebody that is a good fit for it? Is it something you would give them right away? Or is it, again, we're going to try maybe some nutrition interventions first and then potentially go there? Or
Depends on the severity of their disease. If they're seeing me, they probably, one, they've almost certainly tried all the diet and exercise stuff, but we're always going to do those things. If they have type 2 diabetes, heart disease, and I know they've at least tried, they should be on it anyways because we know of the real health benefits in those people. If they have obesity, their BMI is 32, and they don't really have other health problems, absolutely, we're going to try nutrition, exercise, and then maybe some other cheaper but safe, appropriate meds to help them reduce their weight and the future risk of the complications. So everyone's a little bit different. If they have, maybe they don't have type 2 diabetes, but they have heart disease and they have metabolic syndrome, they probably should be on, say, semaglutide, which would be Wegovy, because we know it reduces cardiovascular risks now that came out. It depends, but for me personally, they've usually gone through all those hoops and we're going to be more aggressive with medicine, but maybe primary care, not so much. Kind of depends. But most people who are looking for this stuff, they've been doing it. A lot of people have been trying. And it's not. Anyways, yeah.
I guess for me, this, again, when I first got in the industry, oh, you don't need a supplement, right? You just need, but it's, again, this supplement, medication, whatever you want to call it. Mm-hmm. But again, this is, like we talked about, that vicious cycle where, again, the hunger cues are out of whack. And again, my understanding of GLP-1s is it's really going to help curb that to where, again, like you said, it gets rid of the food noise. And
basically,
less likely to want to consume those kind of empty calories, like you said there.
In simple terms, we've had patients ever since we had these things. I was a fellow at Walter Reed, and we didn't have the weekly stuff yet, but I had somebody on, they type 2 diabetes, obesity. We had a few people, but one particular very smart person who worked at the NIH just struggled whole life trying all the right things. Put him on liraglutide, Saxenda dosing, plus phentermine topiramate, which is like Qsymia, the brand. And he did very well. He put his diabetes in remission, lost 15-20% of his weight. His words that we hear over and over again ever since then were, oh my God, this is what it's like to feel normal. I'm not always like thinking about food and worried about food. And by the way, he was not really into exercising per se, but as his weight went down, his overall non-exercise physical activity kept going up. He was walking everywhere, taking stairs. And so his health, talk about that vicious cycle, it went in the right direction with these things. But it's that, oh wow, this is normal? To not just think about food all the time and always want to go and stop by whatever. That's what we hear all the time.
Yeah. No, that's awesome. I know you are strapped for time. We got to let you go real quick.
Yep. Go for it.
The lean body mass loss. Again, you can just briefly say with that. And then lastly, after you finish that, just let people know where they can find you. And if they ever want to work with you or anything like that, where they can find you there for that.
Yeah. So the scaremongering that came from that actually came from a subpart of one of the first studies of semaglutide Wegovy for obesity. It was a small group of people. They did body composition stuff. We do have a couple of podcasts on this at the Docs Who Lift podcast, going back a couple of years, I think, with body composition expert. And first of all, the data are just DEXA scans are not perfect themselves. We know that those people still had all the health benefits despite having that lean mass loss. And even though it probably wasn't all muscle, but on the other hand, everyone needs to be weight training. And that is the key. Strength training is the key to maintain and gain muscle mass and keeping those health benefits. So we want everyone to do it anyways. So none of this precludes it. Is there a concern? Maybe. But even then, the people still had the health benefits. But yes, everyone needs to strength train. Interestingly, tirzepatide has more potent weight reduction and sugar control. Doesn't seem to have the same signal. So who knows? It could have been a little fluky thing. It seems very unlikely that the semaglutide molecule would specifically cause that. It doesn't make any sense. And either way, just weight train. Don't worry about it. Get the health benefits. It's literally what's on the inside that counts. And so we absolutely want to maintain as much muscle mass as possible. Something to think about. But no matter what you're doing for your weight reduction, you got to do some sort of muscle maintenance. Yeah. And then, like I said, with tirzepatide, Zepbound Mounjaro doesn't seem to have the same thing. But either way, we got to strength train. Please strength train. Push-ups, pull-ups, bands, doesn't matter. Gym, all the things.
I could see people be like, oh, it's not going to help me lose weight, so I'm not going to do it, right? But like you said, the big thing, if you want to lower that risk of losing lean body mass loss, freaking weight train. That's the best way to.
Yeah, it's not about the weight. It's not about the scale. If they gain muscle mass and they go up a couple pounds, awesome. fine, but their health is better. That's what actually matters, not the number on the scale. That just helps us kind of correlate to what health problems might arise or how much benefit we're going to get. And then I guess your second question was only about where the heck I am and where to find us. Social media is just at Dr. Karl Nadolsky. And we're trying to get our Docs Who Lift podcast continued to do our thing with that. And you can find us there. And if you live in Michigan, come see me.
I was going to say, can you work with people virtually?
Yeah, I do. Technically, I have a license in Florida and Michigan. So technically, you need to be in one of those states. Spencer, because he went all virtual, my younger brother who does family medicine and obesity medicine, he ended up getting licensed in almost every state. It seems that might be the way of the future. Certainly seems like doing some in-person stuff is nice and beneficial because it's more personable. But yeah, it's sure nice that we can do virtual medicine too.
Yep, absolutely. Awesome, Karl. Well, really appreciate your time, man. Appreciate you coming on here to chat about this. I know you're a super busy guy, so appreciate it. And we'll talk again soon. Thank you for coming on.
All right, great seeing you.